All right, everyone. Hello. I want to thank all of our viewers and welcome you all to Medical Student Grand Rounds. I'm Bryce Ringwald. I'm a fourth-year medical student and vice president of Student Council. Medical Student Grand Rounds is a lecture series for medical students by medical students. And this series will be a continuous event occurring the first and third Tuesday of the month, starting at 12 p.m., and will continue via Zoom until we can return to Myling lecture halls. Today we have a fantastic presentation lined up for you with Moneer Abouljoud, third-year medical student who will be presenting on combating the stigmatization of men's health. And then later talks, starting on November 3rd, we will have Janice Bonzo. She's a fourth-year medical student. She's going to talk about her time as a member of the Ohio State University Board of Trustees, about leadership and how all of these collective experiences have shaped her career path. And then on November 17th, we will hear from Brian Hansen, who will be presenting on his research project on cardiac arrhythmias and the future of rhythm mapping. But before we start, we still need some medical student speakers for our lecture series in the year 2021. So we would ask that you use the QR code found here to nominate a potential speaker. These can be self-nominations, or you can nominate someone else. We want to be able to represent medical students across all classes who are doing amazing things and give them the opportunity to present and inspire their peers. During this talk, we're going to be utilizing the Q&A function to gather questions during the presentation. We cannot guarantee that we are going to get to all the questions, but we will do our best to get to as many of them as possible. And now I'm going to introduce today's speaker. So Moneer Abouljoud, he's from Detroit, Michigan. He's an aspiring orthopedic surgeon. He has a strong passion for men's health, which led him to start a men's health club at the Ohio State College of Medicine back in 2019 with a group of like-minded classmates. He hopes to continue to educate and advocate about all issues surrounding men's health throughout his career as a physician, as well as to break up the stigma about discussing these issues. Other hobbies that he has includes tennis and golf, playing music, exploring breweries. And today, Moneer is going to be speaking to us about why men tend to avoid talking about their physical and mental health, why they do not seek out professional care when it may be warranted, and the importance of making it a commonplace to have conversations about these issues. Without further ado, I want to hand over the microphone to Moneer Abouljoud.
All right, thank you so much, Bryce. Hello, everybody. As Bryce said, my name is Moneer Abouljoud. I'm an M3 here at the OSU College of Medicine. And today I'll be talking to you all about men's health, the stigma that surrounds men's health, and what we can do to break that stigma. So I first wanted to start with a little intro of why I sort of became so passionate about men's health, why this became something that I want to become a champion for. So a few years ago was the first time that I had a real experience with a friend of mine that had struggles with their mental health. They had approached me saying that they had recently began cutting themselves. And shortly into this conversation, it was disclosed to me that in high school, he had gone up to his attic and almost hung himself. Shortly thereafter, another friend had told me that one night while he was younger, he held a shotgun up to his head for the entire night, and still to this day wasn't exactly sure why he didn't pull the trigger. I also saw someone firsthand try to take a whole bottle of pills right in front of me. It is these experiences that have shown to me the struggles that men face with mental health, and that oftentimes they don't feel comfortable talking about these issues until they've reached a breaking point. They keep them closed in, and it gets worse and worse up until they finally reach that nadir. So it is these experiences, along with so many others, in addition to my own struggles, that have made me so passionate about men's health and make me want to bring up the discussion so that we can save lives. So a little bit more about me. Like Bryce already said, I'm a third year here at OSU Com that is interested in orthopedic surgery. I'm from Detroit, Michigan, technically Grosse Pointe Park on the east side. For undergrad, I went to the University of Dayton in Dayton, Ohio. And other interests might include tennis and golf, piano, guitar, which you can maybe see a couple behind me there, sour beer specifically, shout out to Antiques on High, and powerlifting. Currently retired, hoping to get back into it one day. I have a few learning objectives for this talk. The first one is to recognize factors that prevent men from seeking medical and mental care. Next is to become familiar with some of the male predominant malignancies, specifically testicular and prostate cancer. And third, to identify some ways that you can help change the narrative and break the stigma that surrounds men's health. So throughout the talk, we'll be talking a little bit about what a man is, as well as some quick facts. Then we'll talk about men and going to the doctor. After that, we'll talk specifically about a few issues, including depression and suicide, malignancy, being testicular and prostate cancer, what we can do, and then a little bit about Men's Health Club here at OSU-COM. So first, I'll start with a sort of rhetorical question. That is, what is a man's role in society today? But also, how does this compare to 50 years ago? So in the past, we were a very patriarchal society. Men were seen as providers for the family, while women were typically homemakers. Again, these are not my beliefs, but these were sort of the traditional views. Men went out and worked, women stayed home and took care of the family. But now, as it should be, there's a lot more egalitarian view. Men and women are both providers, both contribute to the home life. There aren't jobs for just men and women really anymore. And with regards to the qualities that make someone a man, the man was typically viewed historically as someone that doesn't show emotion, that is hardened, that doesn't break or bow to anything. Right? A man was always stereotypically tough. But these are views that are changing over time because those stereotypes aren't and shouldn't really be true. And then with regards to some medical struggles that men face today, it sort of echoes these same sort of qualities that make someone a man. Men do not want to go to the doctor because they view themselves as these sometimes impenetrable fortresses. They want to be seen as the tough guy. They don't want to show any weakness or vulnerability. And again, these are more traditional views and they are changing over time, but this is still contributing to some of the medical struggles that men face today in society. Now I'm just going to share a few quick and maybe astonishing facts with you guys. 81% of men remember the make and model of their first car, but less than half remember the last time they went to the doctor. 20.5% of men did not seek care in 2017 compared to only 11% of women. Men die by suicide 3.5 times more often than women do. There are 1 in 2 men diagnosed with cancer in their lifetime versus every 1 in 3 women. About 3 to 35% of these cancer-related deaths could have been prevented. 59% of men over the age of 18 report being screened for cancer versus 95% of women. And a big part of this is due to the earlier implementation of the healthcare world in women versus men. Women are thrust in the healthcare world at an earlier age with things like regular gynecologic exams and breast cancer screenings, whereas men don't really have anything like this. Additionally, men are less likely to be screened for colon cancer, but more likely to test positive if screened than women. Additionally, men die on average 6 years earlier than women, and these are largely due to preventable causes. Over the next 15 years, prostate cancer rates may double. Testicular cancer rates have doubled over the last 50 years. Worldwide, 1 man dies by suicide every minute, accounting for about 75% of suicide deaths. So all of these factors beg the question, why don't men go to the doctor? In 2019, the Cleveland Clinic did a fantastic survey called the Mention It survey, and it brought to light exactly these issues. They showed that 65% of men will wait as long as possible to see the doctor, and that 77% of men in the 35 to 54 range will just try to tough it out until it gets better. They also found that 72% of men would rather do household chores like cleaning, cooking, and 77% would rather go shopping with their significant other than to go see the doctor. 41% were told as children that men don't complain about these issues. 65% will prefer to attempt self-diagnosis. 81% overall would rather see a doctor than crowdsource a diagnosis, with crowdsource meaning go to things like Facebook, Twitter, medical blogs. But 30% in the younger age range, 18 to 34, would prefer to crowdsource than actually go to the clinic. Additionally, when asked what men do to take care of themselves, only 50% selected that they would get an annual checkup, that only half of men would go to the doctor to take care of themselves. This is 26% in 13 to 34-year-olds versus 43 in those that are 35 to 54 and 75% in those over 55. So this is especially problematic in those younger age groups like many of us might be in right now. And this is even though the majority of them, 82%, want to stay healthy and live longer for friends and family who rely on them. Additionally, they may be motivated most to go to the doctor when their health interferes with their work, or if it becomes a burden on friends or family, or if it affects their sex life. So it takes these factors oftentimes for men to go. But even if they go to the doctor, even if men finally decide to go, there are still problems. Because 20% of men admit to not being honest with their doctor. We just need to let that sink in, that 1 in every 5 men at some point is not honest with their doctor. Now, why? Why would men not want to be honest with their doctor? Why would men not want to be honest with the person that is supposed to help take care of them and make them healthy? Turns out there are a lot of reasons. The first of these is shame and judgment. 25% of men have felt judged at some point by their doctor. Additionally, 46% sometimes feel embarrassed when they come with certain problems or uncomfortable. This fear of judgment, this not wanting to be judged, is especially true in the guys that are 35 to 54 compared to the older populations. And additionally, a large fraction of men don't want to know about these potential health problems or what they need to do to fix them. 38% think these problems would just self-resolve on their own. They don't need to go see someone because it's going to take care of itself at some point. 36% didn't want to hear that they should make a diet or lifestyle change, and 37% knew that something was wrong. They knew it, but they were not prepared to face a diagnosis. So they just completely avoided the problem. Additionally, men are especially uncomfortable with discussing below the belt issues. 46% say that sex-related concerns are what they are the least comfortable talking to their doctor about. In addition, they are even more uncomfortable talking about these men-specific issues, these below-the-belt issues, than talking about their weight and diet, their exercise frequency, how much alcohol they drink, if they use any drugs, if they smoke tobacco, if they're adherent to their medications, or if they have blood in their urine. Next, we want to dive specifically into why men don't seek care for their mental health. And I think that we have all maybe heard just be a man at some point, just rub some dirt in it. That is a serious problem for why men don't seek care for their mental health. So per the American Psychological Association, men of all ages and ethnicities are less likely than women to seek help for all sorts of problems, including depression, substance abuse, and stressful life events, even though they encounter these at the same or greater rates as women. Now, this is especially true in some minority populations, including Black men, Latino men, and Asian men. Additionally, 2/3, 66% of mental health outpatient visits were made by women. Now, the American Psychological Association has issued guidelines for treatment of various populations, including LGBTQ+, women and girls, various ethnicities, religions, backgrounds. However, there are currently no guidelines for males. And society demands men to be the stereotypical tough guy, like we mentioned earlier, that is independent and they're unemotional. Additionally, there's this sort of learned inability, reluctance, and unwillingness to seek help. And this is most likely due to socialization and upbringing rather than a programmed genetic factor. This is that nature versus nurture argument. This is a learned behavior. Additionally, there's an emotional self-disconnection. Many men don't realize they're depressed and they can't express their emotion. There's even been a term coined for this by Ronald Levant, which is normative male alexithymia, the inability to express emotion. Additionally, one big factor is masculine role socialization. Men must admit that they need help, but this conflicts with these traditional ideals that we mentioned of what a man is. A man can't admit that he needs help. He's supposed to be tough. He's supposed to just be able to handle it on his own. And according to Jill Berger and Ronald Levant, men with stronger traditional masculine ideologies have a more negative opinion of seeking psychological care. This is further bolstered by Glenn Good, who said that men with higher scores on a test of male gender role conflict, which is this sort of back and forth conflict, this internal fight between these rigid, learned gender roles and the healthy expression of emotion, they are more likely to be depressed and have a negative opinion of counseling. So even these men that realize that there is a healthy expression of emotion are having this internal fight that they can't express it. There are also social norms. Men worry that they will be looked down upon, that seeking or needing help isn't normal. And men that even do eventually go on to seek counseling still do worry about what others may think of them. Jay Wade, the president of the Society for Psychological Study of Men and Masculinity, said that we're self-reliant. We want to do it for ourselves. Men suck it up. We move on. We bury it. We repress it. Additionally, this is a quote from an actual patient. I was not afraid of counseling, maybe because I'm not a very typical male. I tend to be pretty open with my emotions. But I have to be very careful with whom I discuss the issue of being in therapy. I think there's a stigma. People expect men to be strong. Now, just to talk a little bit more specifically about depression and suicide. In 2017, it's almost 17.5 million adults over the age of 18 in the US had at least one major depressive episode. This is 7.1% of all US adults and over 6 million men. Now, 64% of these had severe impairment. And what that means is that it specifically went to significantly impair their life, their work, their relationships, their ability to function. And with regards to treatment, 44% sought therapy and medication, 15% sought therapy, 6% medication only, but 35%, just over 1/3 of all these people, opted to not seek any sort of treatment, whether it be therapy or medication for their depression. There's also 2018 data from the CDC that showed that 48,000 died by suicide from an estimated 1.4 million attempts. And this is most likely an underestimation. There were about 132 suicide deaths per day, and firearms accounted for over 50% of these. Now, the rate was highest in middle-aged white males. White males accounted for 69.7% of all suicide deaths in 2018, and men died by suicide 3.6 times more likely than women. Now, this begs the question, why are men more likely to die from suicide? The reason for this is that men are more likely to use more highly lethal means to actually commit suicide, including firearms. Now, this is in contrast with the fact that women actually attempt more, but they typically use less lethal means. If you look at suicide rates by age, with the exception of men less than 15, rates have been increasing steadily since 2009 over the last 11 or so years. But if you look more closely at a few of these age groups, in men aged 55 to 64, 25 to 34, and 15 to 24, the rates have risen significantly over the last 10 or so years. Additionally, the rates have gone up in several different race and ethnicity groups. As you can see, it's gone up from 13 to about 16% in white men over the last 10 years. In American Indian men, it's gone from about 12 to 13%, and it has also risen in Asian Pacific Islanders and Black men. There's a study done by Ann Cleary called Suicidal Action, Emotional Expression, and Performance of Masculinities that described men with high levels of emotional pain, but with problems identifying symptoms and disclosing this actual stress. Now, this was linked to a form of masculinity prevalent in their social environment. The norms of their social environments discourage disclosure of emotion as well as emotional vulnerability. Now, what did this lead to? This ultimately led to the use of alcohol and drugs to cope with, instead of actually going and talking about it with someone, which ultimately led to exacerbated or prolonged distress, a feeling of limited options, and suicidal action. Now, it's this constrained expression of emotional pain in the context of these social masculine constructs that lead to the opting for suicide rather than disclosing distress and actually seeking the help that they need. Now, moving on to male predominant malignancies, with regards to testicular cancer, 1 in every 250 men will develop testicular cancer at some point in their lives. And the incidence has been rising in the United States. The average age of diagnosis is currently 33, so it's mostly a disease of these younger guys, and it is the second most common malignancy in men aged 15 to 19, second only to leukemia. In 2020 so far, there have been over 9,600 new cases and 440 deaths. And risk factors include undescended testes, family history, HIV infection, carcinoma in situ, prior history of testicular cancer, as well as certain age groups, white race, and body size. That meaning larger body habitus, not necessarily higher weight. Now, as with most malignancies, early detection makes testicular cancer easier to treat, which makes sense. Most are also found at an early stage, and some are asymptomatic until they're at advanced age or advanced stage. Now, some recommend that all men do self-examinations monthly after puberty. Now, this is especially true when there are some of those aforementioned risk factors present. If those risk factors are present, it's recommended that exams are done, as well as that there's a discussion with their doctor. Now, this might seem a little awkward or uncomfortable, but that's really part of why we're having this discussion, is to break the stigma around that surrounds talking about this. And this is how you actually do a self-exam, and it's normally done in the shower. And basically what's done is you look for any new lumps or bumps, firmness, enlargement, and these are typically slower changes that develop over time. So it's really important to monitor those changes over time. Now, it is important to be familiar with the normal male anatomy, because there might be some things that might seem like a lump or bump, but it's actually normal. So it does require some familiarity, and that's why it can be helpful to actually talk with your doctor about these issues. So for all of your guys listening, for all of you, talk to your doctor. So how does this actually present? So this might present, as I mentioned, with a lump on the testicle or a testicle that's swollen or larger than normal. This can sometimes be painful, but most of the time it's actually not. And there also may be a feeling of heaviness or aching in the lower abdomen or scrotum. There are also other signs and symptoms based on certain hormones that can be released from these cancers, including breast growth or soreness, and precocious or early puberty in younger guys. Now, if this is advanced, this can present with signs of metastasis, like low back pain, shortness of breath, cough, coughing up blood, chest pain, stomach pain, headaches, and confusion. Now, the good thing, I guess you could say, about testicular cancer is that it usually can be treated successfully. The risk of death is 1 in about 5,000. And with localized disease or even regional disease, the 5-year survival rates are pretty good. They're 99 and 96% respectively. However, as expected with more distant disease or metastatic disease, this 5-year survival does drop to 73%. Now, compared to a lot of other metastatic cancers, 73% really isn't too bad, right? But what you have to consider is that this is 1 in 4 men. And this is preventable if you just catch it. Now, interestingly, the USPTF actually recommends not routinely screening for testicular cancer. And why is that? It's actually because, per the current data, it might not offer meaningful health benefits given the low incidence and high cure rate. And especially because there are potential harms for false positives, which can induce anxiety, and there can be potential harms from diagnostic tests and procedures. However, as I stated, this is very treatable if it is caught. So it is recommended that you do talk to your doctor about these issues to see if you might be someone that should be checking themselves. Now, with regards to the rate of new cases over time, as you can see here, since 75, the rate of new cases or the incidence has been going up steadily. However, the death rate has actually been decreasing slightly in this time. And the 5-year survival rate has also been going up ever so slightly. Now, moving on to prostate cancer. Unlike testicular cancer, in which 1 in 250 men will develop it, 1 in every 9 men will develop prostate cancer over time. The average age of diagnosis is 66. So it's the disease of these more middle-aged or older men. It's the second most common cancer in men in the US behind non-melanoma skin cancer. In 2020 so far, there have been 192,000 new cases and 33,000 deaths so far from prostate cancer or complications related to prostate cancer. Now, with regard to prostate cancer, there are both modifiable and non-modifiable risk factors. These non-modifiable risk factors include age over 50, certain races, including African American and Caribbean men, geography, so where you live, as well as family history and genetics, such as BRCA1 and 2 mutations and HNPCC or Lynch syndrome. Now, there are a few factors that show that there could be a potential link to prostate cancer, but they are less clear with regards to how they actually affect it. The relationship is a little less well-defined, and that includes poor diet, obesity, smoking or tobacco use, certain chemical exposures, as well as history of prostatitis or infection of the prostate, sexually transmitted infections, or history of vasectomy. So prostate cancer is the second leading cause of cancer-related death in American men. 1 in 41 will die of prostate cancer at some point in their lives. However, most men that are diagnosed do not die. Actually, there are 3.1 million men plus in the US that have had prostate cancer at some point, but are still living today. Now, how does this present? This presents with trouble urinating, decreased force of stream, blood in the semen, pelvic discomfort, bone pain if there are mets to the bone, which is very common, and erectile dysfunction. However, it can also be relatively asymptomatic. So this is tricky because it is hard sometimes to distinguish between prostate cancer and benign prostatic hyperplasia, which is just benign enlargement of the prostate. And this is especially common in these older men. It's a very normal part of aging, and a lot of times these symptoms present similarly. But with regards to the asymptomatic presentation of prostate cancer, sometimes this cancer can grow in an area that doesn't directly surround the urethra, and there aren't these urinary symptoms, so it might not present until a later stage. So this begs the question, how do we monitor for this? How do we screen for this? So there are a few different ways that screening can be done for prostate cancer. The first is a blood test, which looks for something called prostate-specific antigen, or PSA. And the second is by a digital rectal exam, which is feeling for prostate cancer with your finger. If detected in an early stage, as again with most malignancies, it is easier to treat. However, there is a large controversy that surrounds screening for prostate cancer. Now, why is this? Why would there be controversy about screening for something that could be potentially lethal? Well, the first of these reasons is that results can potentially be inaccurate. Additionally, screening for things like prostate specific antigen, or PSA, or even the DREs, if there's any potential lumps noted that aren't truly malignant, can lead to overdiagnosis of prostate cancer as well as overtreatment. This will eventually lead to increased morbidity, including urinary and bowel side effects or sexual side effects. So instead of doing this, there are a few different methods that are employed that can be used for people that may have prostate cancer. There's something called active surveillance, and there's something called watchful waiting. So active surveillance is a little closer of a monitoring than watchful waiting. It usually involves a clinic visit and a PSA, or prostate-specific antigen blood test, every 6 months, and a digital rectal exam at least once yearly. Biopsies and imaging can be done every 1 to 3 years if it's deemed necessary. And based on changes in these results, changes in these tests, treatment can be pursued. Now, it has been found that men who undergo surgery or radiation actually do not appear to live longer than those undergoing active surveillance, but the cancer might stay away for a little longer or spread less ultimately. Now, the other side of this coin is watchful waiting, which is really more observation. This is a less intensive type of follow-up and involves fewer tests and relies more on these symptomatic changes in order to help facilitate and indicate treatment. And treatment in these men most often actually is for symptomatic control rather than cure of the cancer. Now, some studies have found that those with surgery might live longer. However, others have found that there's actually no difference in survival rates. So with regards to treatment outcomes for prostate cancer, it does depend on the extent of the disease. So for localized and regional disease, as with testicular cancer, the 5-year survival rate is actually pretty good. It's nearly 100%. But once you get those distant metastases, it drops to 31%, which is a significant drop from localized and regional disease. With regards to screening recommendations from the USPTF, there are actually sort of 2 different classes of recommendations. In men aged 55 to 69, when this most commonly occurs, the decision to be screened for prostate cancer is an individual decision. It's based on whether a man would like to be screened, and it might warrant a discussion with your doctor. This is the typical age that men will have onset of prostate cancer. But in men aged that are 70 and older, it's actually recommended that they are not screened for prostate cancer. Now, why is this? This is because in this age group, it is much less likely to become an extremely malignant or lethal process, and the pros of treatment actually do not outweigh the cons of screening and treatment in this age group. Now, interestingly, in the last 30 or so years, the rate of new cases has been dropping a little bit, as well as the death rate because of this earlier detection. So what can we do? What can we do about all of these issues that I just mentioned? What can we do about men not going to the doctor and about maybe going to seek help and treatment for these preventable issues? So again, from that Cleveland Clinic Mention It survey, flexibility and convenience are really important factors for men. 61% would be more likely to get annual checkups if it was more convenient for them. Now, what does this increased convenience actually look like? This might look like virtual visits, which a lot of us might be experiencing now in the times of COVID with Zoom and telemedicine. This might look like scheduling appointments outside of normal work hours. You know, a lot of men have the traditional ideal of they need to work and they need to provide for their family, and they can't take time off to look after their own health. Additionally, because men can be lazy sometimes when it's regards to their own health, they might be more likely to actually go to the doctor when they have someone make an appointment for them. Additionally, getting screened at events that they're already participating in makes them more likely to participate in these screenings. Now, some of these factors and some of this has already been put into practice with regards to some hospitals. It might help men if they create systems that are easier for men to get care, such as men's health centers. One such center actually exists at the Cleveland Clinic Center for Men's Health. Here you can schedule appointments with multiple providers in the same visit. Additionally, there are similar systems at the NYU Langone Men's Health Center. Additionally, even just making the office a more comfortable place to be might make men more likely to want to go. When you typically think of the doctor's office, you think of this sort of white, sterile, extremely bright, not so welcoming place. And it's not really drawing anybody in. And places like Mount Sinai have partnered with a nonprofit called Man Cave Health to actually make their offices a little more sort of welcoming for men. As you can see in this top picture here, Ash Tawari, a prostate cancer surgeon and chair of Mount Sinai's urology department, is in their urology waiting room. That's sort of like this man cave with sports memorabilia, a coffee bar, and it's really just a welcoming place to be. NYU Langone has done something similar, and they made their clinic look a little bit more like a corporate or midtown office building. Additionally, the use of technology can help men to get providers, and this might actually avoid the potential embarrassment that can be associated in some men with going to the doctor's office. There are also live video consult services such as Teledoc and asynchronous consult services. For example, there's something called Bright MD in Portland, Oregon, and they utilize a software called Smart Exam. And this is used by healthcare providers and health systems to offer 24/7 access to care for common problems. And they actually treat over 470 common problems in men like low back pain, depression, urinary tract infections, and erectile dysfunction. Now, this utilizes artificial intelligence and clinicians, with artificial intelligence suggesting a diagnosis and treatment plan, and then the clinician ultimately will review it and then prescribe treatments if necessary. So it's a really smooth, streamlined system, especially for these like potentially quicker issues. Additionally, men who are surrounded by a supportive group that encourages the sharing of their problems and actually seeking support might be more likely to seek help, because men are more likely to seek help for problems that they think are normal. So if they have a supportive group around them that helps to normalize issues that men might face, they're more likely to actually reach out. If they are seen as problems that other men might have too, it provides validation. And this is especially seen with problems such as erectile dysfunction. Now, I can specifically recall when I was a kid and I'd be watching ESPN or watching football games, and I'm sure that some of you can emulate this, but you see a commercial for Cialis or Viagra on, and I remember watching with my dad. He would make the same jokes every time about how all the men watching are these middle-aged guys with ED and they need their pills, but it's normalized this issue. It's normalized the idea that erectile dysfunction is a normal problem. And if we can do that with some of these other issues too, it might make men more likely to actually seek out care. Additionally, per a study done in the Journal of Counseling Psychology, terminology is actually important for things like therapy. In this study, brochures were placed for campus counseling centers around community college students in male predominant areas in things like auto mechanics, welding, shop, the trades, other traditionally male predominant areas. And it was found that men are actually more likely to seek assistance if they received a brochure using the term consultations rather than therapy. In addition, they were more likely to seek help if these brochures emphasize self-help and achievement rather than therapy. Another study, an Australian psychologist found that men prefer transparency with regards to treatment. They want a clear structure for their therapy. They want something that focuses on individualized goals, actual expected progress, and establishment of trust and sharing of decisional control with their therapist. They want something a little more concrete. They want an end in sight. Additionally, it's most engaging to provide an action-oriented functional treatment and targeted skills attainment, or actually doing versus pure talk therapy. This creates feelings of strength and empowerment in men. So after talking about all of this, it's clear that it's not one distinct thing that needs changing. We must change this actual societal norms, how we talk about these issues, how we think about these issues in order to address the problems associated with men's health. It's not a quick fix. It is not quick to change how a whole group thinks about something, how we communicate, how we approach our health. But we are slowly making strides towards these changes. Additionally, there are lots of organizations that have been put in place to help with these issues. The first of which is the Movember Foundation. And this is a foundation that's very near and dear to me, as well as a lot of my classmates and friends here at Ohio State. And this is a nonprofit organization that raises awareness and funds for men's health issues that I mentioned today: depression, suicide, testicular, and prostate cancer. Additionally, there is the Real Men and Real Depression campaign, which was launched in the early 2000s from the National Institute of Mental Health within the NIH to make it more normalized that men have depression, struggle with these issues. A similar campaign was done with the NFL and their Tackling Men's Health campaign. There's additionally Are You OK Day, which encourages people to support those struggling with their lives by starting a conversation. The organization Mates in Construction in the UK involves training, and it's a training and support program that raises awareness of the high suicide rates in construction workers, and it shows them how they can be a part of the solution. There's also Project 84 in the UK, so named to represent the 84 men who die weekly by suicide in the UK, which focuses on the impact that suicide has on loved ones. And this can counteract the sense in men that it's the right thing to take themselves out of the equation to make life easier for those in their lives. Additionally, the UK in 2018 nominated its very first Minister for Suicide Prevention. Now, as I said, a lot of these issues are very near and dear to me. So in 2019, myself, as well as three of my good friends and classmates, Kyle Kopacek, Matt Cephalou, and Danny Lynch, founded the Men's Health Club here at the Ohio State University College of Medicine. We all have a strong passion for men's health and our own individual reasons for why we want to get into men's health. So what is our purpose? Why did we start this? We want to promote men's physical, mental, and emotional health and wellness, discuss and bring awareness to these men's health issues, as well as raise funds towards men's health initiatives. We also want to discuss what it means to be a man today and promote discussion and critical thinking towards men's health, as well as the healthy societal role of men in today's society and how that's changed over time. So as I mentioned, last year was our inaugural year. So what did we do? So we had the incredible opportunity to work with the James Cancer Hospital, and with their partnership, we were able to have several different events throughout the month of November. The first of which was the OSU Healthy Community Day, in which we actually met with and spoke with people out in the community that wanted to take the initiative to talk about their health and get screened or get information about several other problems. But we had the opportunity to actually interact with them, give them information. We did something similar at a Fan Fest booth at the OSU versus Maryland game, where we were able to talk to people about their health, both men and wives, children, families, about the men in their lives, and also hand them some information about some of the rates of things that I've talked about, as well as screening recommendations and what they can do to make the men in their lives healthier. We had a similar outreach event at the Ohio Union for our undergrads here. And as you can see in the lower picture, we had our first annual Mustache Bash, which was a fun little party sort of event where we had everybody there in mustaches or fake mustaches. And we used this as a fundraiser to raise funds for the Movember Foundation, where we raised over $2,000. And as I mentioned, the Movember Foundation is a non-for-profit institution that raises funds towards men's health initiatives surrounding depression, suicide, testicular, and prostate cancer. Throughout all of these events, we tallied over 800 interactions and 300 meaningful interactions or long conversations about men's health and distributed educational resources. So we have a few future goals as well. We want to continue the work that's already been done by expanding public knowledge about the unique health issues that men face, as well as empowering men to take steps to prevent and treat health issues and discuss their health. We also, in the long term, want to implement educational lecture series about men's health topics and set up an endowed scholarship for medical student research in men's health. So we've gone through a lot, and I just want to recap a little bit about what we can do, what you can do to tackle these issues. So the first thing is to just ask the men in your life how they're doing. Now, it's really easy when you have these conversations to just like, how's it going? Good, good, good. A lot of the times that's not true, and it's important to ask how they're really doing and to have that deeper conversation. Additionally, you can ask the men in your life if they've talked to their doctor about their mental and physical health, or if they've even gone to the doctor recently. You can check up on someone that you haven't checked up on in a while. And you can keep the conversation about men's health going and help break the stigma that surrounds men's health. So I'd like to thank the men that started Men's Health Club with me, Matt, Danny, and Kyle, the Med Student Grand Rounds Board, Dr. Chen and Dr. Paul Monk at the James, who've been our advisors and helped us along the way, all the guys in this picture here and so many more that have helped us with our events, with Movember, and helped spread awareness about men's health, and sort of everybody that's helped me along this journey. Without you, it wouldn't be possible, and together we can help break the stigma that surrounds men's health and to help prevent men from dying early, preventable causes. If you ever have any questions, you can feel free to reach out to me via email or Twitter and let me know if you want to get involved. So thank you so much, everybody.
Awesome. Thank you, Moneer. That was a wonderful presentation. I especially appreciate how vulnerable you were to speak on these issues. Q&A has a couple of acknowledgements congratulating you on the great job that you're doing. We'll be sure to get you all of those at the end. At this time, we're going to open the floor to questions. So utilize that Q&A button down there. Put your questions in there. We probably can't get to all of the questions, but we're going to get to as many of them as possible. In addition, on the slide that you see there, there's a QR code that will link you to the feedback for this presentation. Give us some feedback on how we're doing, how Moneer did, and how we can best serve you guys going forward. To kick things off, I wanted to start by posing to you the first question. In regards to diagnosing things like testicular cancer, we know that it occurs in a younger age group, teens into your 30s. Mm-hmm. Now, this age group is usually a relatively healthy age group, and as such, they don't come to the doctor as often, right? Mm-hmm. They don't often come in for yearly physicals just to check in on their health and to ensure that nothing is wrong. Mm-hmm. What ways can we best approach this specific group, these younger individuals who usually relatively healthy, to ensure that nothing is wrong with them?
So just to recap, your question is why, can you repeat that? And I'm sorry, Bryce.
Yeah, my question is how do we get younger men to go to the doctor to ensure that nothing is wrong with them?
Yeah, so I think a big part of this is making sure that we tell men that these are the ages that things happen. And even though we're at that younger age where we typically are healthy, in general, these, younger men aren't affected by things like cardiovascular disease and high blood pressure. But we have to make sure that it's communicated that these are the normal age ranges for things like this to happen, and that men at this age aren't really invulnerable, that they aren't immune to all of these issues. There are other things that do affect the people at an earlier age too. Now, this isn't a male specific thing, but things like leukemia affects people at a younger age as well. And it's known, this is known, but there is that sort of sense of invincibility when you're a younger age. So it's important to communicate to men that, yes, we are typically healthy, especially at these younger ages, but we are not completely invincible to all of these issues. And these are the numbers, this is who it tends to affect. So it's worth a conversation. We have to, again, just like with everything else, we have to normalize these issues and make it clear that this is just when these things sort of happen.
Thanks. The next question that we have is, does OSU, does the medical center have any men's health initiatives similar to what the Cleveland Clinic has?
So as far as I know at this point in time, I do not believe there is something similar to the systems that can be seen at the Cleveland Clinic. At one point in time, I think it was in maybe the earlier 2000s, they were doing a larger group sort of mass prostate cancer screenings out in the community. And, this was obviously with good intent, and it was to try to help catch and treat some of these prostate cancers. But they encountered the issue that I actually mentioned earlier, which is that, should we screen, should we not, because there's a potential for overdiagnosis and overtreatment. So there was something somewhat similar, but actually, no, I don't think there's anything currently in place where you can, let's say, go to the doctor and see your urologist and your cardiologist at the same time. That I know of, I should say.
Sure.
Yeah.
The next question that we have is, what suggestions do you have for getting past the initial "Hi, how are you?" With a man who may be resistant to opening up to a healthcare provider or even a friend or a family member?
Mm-hmm. Yeah, this is definitely a tough one. I think it's something that we have maybe all experienced at some point in our lives, and something that I've experienced too, both with maybe people that don't want to open up, or even when I have not really wanted to open up. I think that something that helps a lot of guys to have these conversations is putting yourself out there as well, making yourself more open and vulnerable. Because if you sort of open your arms like that and show them that it's okay to, that might open the door for them to feel like, oh, we're having that kind of conversation. It's okay. And we've heard about this concept of the heart to heart, and this is sort of something similar. If you show that it's normal, if you show that this is an okay thing to do, that can help to get past that initial "Hi, how are you? I'm doing good," and maybe help people open up a little more. Again, we have to normalize these issues and normalize talking about this so that men feel more comfortable with having these conversations.
The next question we have is something I think that a lot of guys our age can relate to. Is, I'm a 25-year-old guy, doesn't have a primary care physician. Do you have any advice on where to start?
Yeah. First thing first, if you have insurance, I guess see where your insurance covers, and then just go to the doctor. Establishing care with someone over a long period of time can be a really useful thing, and a lot of times great relationships are built with your primary care physicians. But that first step is really just to go out and make an appointment, and it doesn't even have to be for anything specific. You do not have to make an appointment and be like, oh, it's because I have a cough, it's because I'm sick, it's because I have a cold. You can literally just make an appointment for a checkup and to establish care. That is a valid reason for making an appointment with a primary physician. And it's that easy. It really is. And it's so important, and it can end up helping you so much throughout your life. And these are, if you have a relationship with a physician like that, it makes it that much easier to go back to them for care in the future. And especially if you have a long-term relationship with your primary physician, they understand you as a person and as a patient better. So it just involves reaching out to someone or reaching out to a doctor. And it looks like someone just said you get one free physical per year under all insurance plans since the ACA went into effect. Thank you. It's very helpful.
Yeah, so that's a great resource to use. And the last question that we have on here actually is, as a first-year medical student, how can I get involved in the Men's Health Club?
Yeah, so I am not the current leadership of the organization anymore. We actually had a handoff to our new executive board, and that is Rohan Mittal, Kyle Diesler, and Ty Gilkey. I believe they are having their introductory meeting actually this week. I'm not sure if it's today or tomorrow, but I think an email was sent out. So I highly, highly recommend that you attend this meeting, and there's going to be some great information provided on plans that they have for this year, especially with Movember coming up just around the corner. As you can see, I'm kind of growing my beard out because I need my mustache for November 1st for Movember. But I would say attend that meeting, reach out to them, or if you even reach out to me, you can shoot me an email or reach out to me on Twitter. and I can help you get involved.
Awesome. And as we wind down, I want to ask one final question to you. For all the men out there, what are your final words for them specifically?
So to all the men that are out there listening and that will be listening to this in the future, I challenge you to do a few things. I challenge you, first of all, to be introspective. I challenge you to think about how you're feeling, to think about if you are feeling down, if you're depressed, to think about if you are depressed, to go and seek help or to talk to someone. This can be talking to a friend, talking to a significant other, talking to a family member, talking to a doctor, to a therapist, to a social worker, to anybody, but to just reach out and talk to somebody. I also challenge you to take your health into your own hands. If you're sick or you feel like something might be wrong, I challenge you to go to the doctor and to not just tough it out and hope it just gets better on its own if it's something that could be potentially treatable. I also challenge you to talk to the men in your lives, whether it's your brother, your dad, your uncle, your grandpa, your son. Talk to them and talk to the men in your lives and ask them how they're doing. If they've been going to the doctor, if they've been taking their care into their own hands, ask them how they're really doing. And I challenge you to talk about men's health early and often and to help change that narrative and make it commonplace to talk about all these issues I talked about today.
I think those are all great challenges. And thank you again, Moneer, for taking the opportunity to present with us today. I think we've all learned a little something from this presentation. I also want to thank all of our attendees today who have joined us. And just a reminder that 2 weeks from now on Election Day, November 3rd, we'll be having Janice Bonzu giving us a presentation about her time on the OSU Board of Trustees. And we just ask that you continue to tune into us the first and third Tuesday of every month and learn along with us. Thank you, everyone.
Thank you, everyone.